Thank you, Lauren, and good evening, everybody. It's my pleasure to be with you guys tonight and talking about this controversial subject. And I hope that I will explain some of the views that it is important for everybody about this subject in particular. So the title of the subject is there a role for stem cell therapy in treating autonomic disorders. So why we are saying that? So the background for this is, does dysautonomia or autonomic dysfunction has a relationship with autoimmune? And this has been investigated since mid 90s with several investigators. And I just placed a few of the studies that has been reporting the relationship between autonomic nervous system and autoimmune part. So there was a nice study where they cut the recurrent laryngeal nerve, and probably some of you know that the recurrent laryngeal nerve is wrapping around the aortic arch, and it also supplies the thymus gland. And they saw that there is a change in the T cell production in lymphocytes in the thymus gland after they did that. So that was the first hint that it might be the vagal nerve has something to do with the thymus, which is a major component of our immune system. And next to that, they did the hyperthermia, which is kind of thalamus control that control our temperature, and they blocked the interleukin 1 by subdiaphragmatic vagotomy. So they did cut the vagal nerve at the level of the diaphragm, and they saw that there is modulation of this temperature control. In the same time, they did also hypothalamic ACTH secretion has been also changed with the diaphragmatic vagotomy. Also, the relationship between the cytokine or the interleukin 1B in the brain and also in the blood has been also seen in the rat model. I will say Kevin Tracy in almost 2000, he did a very nice study where he did a control sham study and experiment rat, and he did bilateral cervical vagotomy and showed that the vagal nerve has a response to inflammatory response to endotoxin. So he gave these rats endotoxin and cut the vagal nerve in some of them they didn't, and the response of the cytokines was totally different between these two models. And then he proposed later on what we call it the inflammatory reflex. So when, as you can see here, when a pathogen or bacteria that attacks one of the cells in our body, it will release something called cytokines or the interleukins. And these are very important inflammatory substances that it can be detected by the afferent vagal nerve, goes all the way to the brain, modulated by the cholinergic brain network. And the efferent part, it goes to the macrophages, and these macrophages can be modulating the amount of cytokines released by these macrophages. So the cytokines themselves, they can have a negative feedback on the cytokine production from the macrophages. And that's what we call it the autonomic immune response. Um, of course, the idea of immune homeostasis and allostasis has been really studied very well. So the TNF, which is that tumor necrosis factor, and other cytokines, has been really increased in the damage of the tissue, even without the damage of the, pain, depression. You start to increase your cytokines in your body, and then when this is what we call it the allostasis. And of course, the more intense is the reaction, especially in the septic shock and tissue damage, you will have higher autonomic nervous system modulation with these cytokines, or what you call it, the allostasis. So we know that there is nicotinic and muscarinic acetylcholine receptors in the body, and I will not go on the details of that because, but we know that the nicotinic part is really in the periphery and just and sometimes in the end organs itself, and it can be modulated centrally by the vagal nerve and the nucleus of the vagal nerve. And very important that also the parasympathetic nerve is ending by multiple endothelial tissue. And that can explain a lot of the symptoms that we see in those patients who had uh, um, dysautonomia and they have nausea, for example, or stomach pain or constipation. So it can supply even pancreas and the glucose and glucagon production. It can supply the liver, the lungs. So many organs, you will have an end of parasympathetic nervous system. So modulation of this can modulate a lot of functions of these end organs by the vagal nerve. So Dr. Bernino and his group also they specifically noted that there is an autoantibodies that it is directed to the receptors of ganglionopathies, and they found that there is a big symptoms of those patients, and those usually between mid-age men and women who had these symptoms of dysautonomia. And these are the antibodies directed again to the acetylcholine receptors. So acetylcholine, as we know, it is an autonomic nervous system, but also this is antibodies, which is an autoimmune process. And they found that this is a specific subunits, which is alpha 3 subunits, which is a nicotinic acetylcholine receptors that it can be affected by these antibodies. And this is very important because, those patients, when they notice that they have a lot of autonomic nervous system dysfunction, tachycardia, nausea and vomiting, fatigue, actually it's excessive fatigue, blood pressure dysregulation, and they have syncopal episode, and it can happen very suddenly in those patients, and then they will find that these patients they will have positive antibodies for this. It's not only for that. We saw that there is some antibodies related to paraneoplastic autonomic disorders, and multiple of that. Anti-Ho is the famous one for this. Lambert-Eaton myasthenic syndrome, which is also another antibodies directed to the calcium channels. Morvan syndrome, which is antibodies directed to potassium channel. And this will activate also, you can see here, excessive salivation, stiffness, hyperhidrosis, and tachycardia. So you can see that there is antibodies that it can produce autonomic nervous system dysfunction. Limbic encephalitis and the famous one, the Guillain-Barré syndrome, which is we know that it can have a lot of autonomic dysfunction with those patients who has antibodies. Uh, so we started in children and young adults to have suspicion about this autoimmune process by their disease, and we see a lot of them they have either thyroid disease, gluten sensitivity, whether it is celiac or not non-celiac. They have also musculoskeletal symptoms, fatigue, the muscle pain, joint pain, skin rashes and hives, and excessive sweating, flushed face, and temperature instability. You can see that these are common symptoms between autonomic dysfunction and also autoimmune disease. So we decided, and you can see this is our questionnaire we use, and there is a big section here. I'm sorry it is not so clear to you guys, but you can see there's a big section about GI, skin, and joint and muscle. So we ask these questions, and we ask patients to have between 0 to 4. 4 is the high intensity symptom, and the lowest will be, of course, 0. And we see a lot of 3 and 4s in those patients of either it is skin or GI or joint and muscle related things. We thought that there must be an autoimmune process going on in those patients. So we decided to do a general study to measure all of these autoimmune panel, we call it, in these dysautonomia patients. And mainly we look at the cytokines in very detailed one. So initially we were sending out all of these cytokines for a lab in Utah, and then after that we had it in our lab for the last 7 years now. So all of these cytokines we are looking at, assay for each one of them. Celiac also we look at different antibodies and antigens, complements factor, which is C3 and C4, thyroid antibodies, which is peroxidase and thyroglobulin, of course, ANA and DNA antibodies, and gastric parietal cell antibody. We and this is really, it was interesting to study that. And then alpha hydroxylase, which is also can contribute to Addison disease and this. So we decided to study all of these antibodies in each patient that comes as a newcomer. So over 5 years study period, we have 758 new patients. 530 of them, they agreed to proceed to autoimmune panel for those patients. And you can see here that the main median age is about 15 years, and they have documented history of dysautonomia. So we found that, which is very interesting, that there was a positive one antibody at least out of this panel. So we have in 84% of the patients. So it's huge. It was really a big study for us to show that autoimmune is playing a major role on those patients. And remind you that those patients didn't come for autoimmune disease for us. They come with tachycardia, the low blood pressure, fainting, dizziness, all of these dysautonomia symptoms. And we studied their autoimmune, and we found that high prevalence of autoimmunity in those. So, and interestingly also, the major player in this is the cytokines, you can see, and which is consisting with the studies that has been done by early investigators in the 90s and early 2000, that the cytokines major role in this autoimmune mediated autonomic dysfunction. Celiac and antinuclear antibody, gastric parietal cell, 131 patients they have it positive. You can see that it is really very high. And not only that, we correlated this with some of the symptoms, and you can see that the correlation was in, for example, intestinal symptoms and cytokines. In positive patients, they have it higher, in relationship to negative, as well as anti-nuclear antibody and fatigue, and in the same time the excessive sweating and celiac with the nausea. So it's also correlated with some of their symptoms when we studied that in this. Now I will shift gears a little bit and talk about the stem cells. Why I'm talking about that, and I will explain later that what's the role of stem cells in all of this. So as we know that stem cells are the precursors of all the cells that it is produced by our body. And usually we have the properties of stem cells, they have to be self-renewal. So that means that they can divide and have more production of stem cells in the body itself. And the second one is multipotency, means that they are having an ability to change these cells into different cell types or cell morphologies. So they start by stem cell, then they will end by another morphology or stem cell type. So that's by itself is defining them. And the famous one is the inner cell from embryoblast. These are almost like 50 to 150 cells in the embryological life, which happen about 5 days of the embryo. And those cells, these ones that you see in front of you, are responsible for all the differentiation of the cells that we have in our body, including bone, including hematopoietic, including muscles and heart, and all of these are coming from these stem cells that it is in the early embryoblast one. So we see that the stem cells are several one. This is the embryonic one, we call it, that's it is, you see it also in the umbilical cord, blood, but also the adult somatic cells. We know that each somatic part of our body has stem cells to renew that. bone marrow, which is the hematopoietic one, and this is very important, which is the adipose tissue, which is, we see that a lot of stem cells coming from the adipose tissue or derived from the adipose tissue. So the embryonic stem cells, we said that they are pluripotent, means that they are the ones that produce most of the cells that we have in our body. Adult cells, they can differentiate into the what you call somatic or tissue-specific stem cells. So the ones in the bone marrow, they will produce red blood cells and white blood cells. The ones in the heart, they will produce myocytes. The one in the liver, they will produce hepatocytes. So each cell is specific for those ones that it is coming from the original of it. Then we spoke about how potent they are. Of course, the embryological one is the most potent. Then we see some of them, they will be only producing one subtype of the cells. Now, when we talk about the mesenchymal stem cells, they are coming mainly from, and we, in our study, we look at the fat or the adipose tissue stem cells. So this will can be extracted from the adipose tissue. Then you can isolate these stem cells. And this is a very important step, as we call it, induction or induce stem cells to produce the cell type that you want that. And this will, create a tissue stem cells that it is ending by the organ stem cells that it is coming from that. So this is a picture that you will, that's how, and we'll talk about that in the study itself itself. This is adipose tissue that it is coming from the adipose tissue. And you can do centrifuge that, and you can take the stem cells coming from the adipose tissue and then culture it. And this culture and the induction of the stem cells is very important, I would say, a step in production of this, because those stem cells, they can produce into millions and millions of cells in the outside the body. And you can see here, these are the stem cells, the mesenchymal stem cells that they can produce from the tissue of the adipose tissue. Now, so the mesenchymal stem cells, they are, we call it stromal cells, means that they are coming from the systemic or the body. So it's they are very differentiating into different properties. And the most attractive feature of these mesenchymal stem cells, they are different into, we call it plasticity, which can be differentiated into several types of some of stem cells. I mean, from cell types. And then they are a tropism, which is ability of the cell to repair the damage or to migrate to the damage. So if the damage is going into certain area of the body, they can migrate to those ones, and we call this tropism. They are very distinguished from the other cells by their surface markers, and lab that we have collaboration with, they use these as surface markers to they have the expression of that, and they don't produce these cell markers. So very important when they differentiate these ones. So they have a central role in tissue repair. They can repair the tissue, especially from tumor, fibrosis, inflammation, and all bacterial infection. And they can produce a very good tissue repair because of that. Also, they have regeneration medicine. So they can regenerate some of the cells that it is in the body by going to that organ and generate some of these cells. So this is our report of the first report about the stem cells therapy into dysautonomia patients. And we reported this in 2017 of 2 patients mainly that they had a very, I will say, intense dysautonomia. And I will talk about one patient in particularly as the index case for us. And we reported this, and since that time, there was a large interest of the dysautonomia and stem cells. So this patient, which is reference case number 1, I will say, She is a 17-year-old young lady who have severe symptoms of orthostatic intolerance. And she started about 12 years of her age. And she progressed over years, and she was almost wheelchair bound after that. She was really very active. She had her mom has a farm of horses, and she loved to be in the horses. But since her symptoms, she will have less and less to be done. She had major GI symptoms, and she was having a lot of nausea and vomiting. And not only that, she has also inability to swallow or dysphagia, and she ended by NG feeding because of this. She had, of course, palpitation, chest pain, dizziness every day. She had several syncopal episodes and brain fog with flushed face. She had also severe migraine headaches, and the neurological was classifying it as hemiplegic form of the migraine. Then, when we studied her autoimmune process, we have several positive autoimmune panels, including rheumatoid factor, gastric parietal cell antibodies, which is, as some of you know, that has been associated with Sjogren's disease, elevated antinuclear antibodies, elevated cytokines, several of them. You can see here how many cytokines she has it elevated in her body. She had also thyroid peroxidase antibodies, and also there's celiac antibodies with DNAs and antifolate antibodies. So you can see that she is having a plethora or the textbook of antibodies in her body, unfortunately. She had missed a lot of school days. She has to pause about uh, uh, 1 or 2 years of her school because of her symptoms, because she was very severe. Then we did a head-up tilt-table test, and we had initially increase of her heart rate to 160 beats per minute upon upright, and immediately she had a bradycardia in 4 minutes of the head-up, with developed sharp decrease in her cerebral perfusion, and we do that by near-infrared regional spectroscopy that we do with that. Then she had short convulsions because of the brain anoxia happened to her with a decrease of her cerebral perfusion. Once we put her back into supine, she had aborted convulsions, and also she had regained her consciousness. So we call her a severe dysautonomia, and we said that it has a mixed type of POTS and neurocardiogenic syncope in her case. So to manage her, we did as every center. I'm sure some of you you had like these patients. So we had sometimes short runs of TPN because she can't even have enough motility of her intestine to digest her food. She lost a lot of weight. She was 17 years, and her weight is almost like 60 or 70 pounds at that point. She lost a lot of weight. And she was treated for rheumatoid arthritis, and she received systemic intravenous immunoglobulin, immune modulation, Remicade, and plasmapheresis. She was really very not responding to all of this. She will respond very shortly for plasmapheresis and IVIG, but immediately in about a month or so, she will come back to her symptoms immediately. She received also amitriptans, rizatriptan. You can see the medication here. For her dysautonomia, received floranef, propranolol, atenolol, midodrine, cromolyn sodium, pyridostigmine, octreotide. So all the medication that you see in the dysautonomia group, you will see that has been tried on her. And as I said, she will respond shortly for this medication, and still she will not be able to function as a student, and she missed a lot of school days. Of course, she developed some anxiety and depression, and she has to take some of these medication for that. So they decided at that point, that was in 2016, still the FDA, and of course, still we don't have the FDA approval for this, but at that point, the stem cells, they were in the beginning of the trials. So she decided to go with her mom to Mexico to receive adipose tissue mesenchymal, autologous mesenchymal stem cells. So they took her fat tissue, isolated the stem cells from there, and they reproduce it in million. I will not go over this in details. This is the methods, and we described it in our paper how they isolated the adipose tissue. They got about 20 ml of autologous abdominal subcutaneous fat tissue to isolate that. And of course, they looked at these cell markers to make sure that we are dealing with mesenchymal stem cells rather than other cells. And they multiply it by millions. Then after the infusion, so this is before, and this is in our paper again, you can see here before the mesenchymal stem cells, you can see here how is the cytokines that we elevated the heart rate, and also she had a syncopal episode with perfusion and decrease of that, and severe sympathetic tone by Fourier analysis. And then after the mesenchymal stem cells, you can see that all of these markers has decreased remarkably. And this is we are talking about in less than 3 months of the stem cell therapy. And she completed 30 minutes of upright position after that by the head up tiltable test without fainting, without any. She had little bit of tachycardia. Her heart rate, as I said, in the tilt went up to 95 instead of 150 before. And definitely she had improvement of the cerebral perfusion and also the sympathetic activity. So we have it objectively. It's not only what she feels subjectively. We did also objectively what are the markers or the parameters that we can see in those patients after the stem cells, and we saw that very high decrease or very significant decrease on the cytokines and interleukins, as well as also her rheumatoid factor came to be negative. I didn't put all the autoimmune panel that we saw in her, but a lot of panel that has been decreasing and improving. So in her follow-up, now she is, I just saw her about 2 months ago. She's 34-year-old now. She's married. She had 3 children. She works in a full-time job, and she came back to riding horses after all these years of. So it was amazing, and actually we had the local TV interviewed her for that, and it was an amazing story to share with people. The second patient was he was about 8 years old who has rheumatoid arthritis. He developed pericardial effusion and also pleural effusion. He has a lot of dysautonomia symptoms, including fatigue and tachycardia with and dizziness with fainting. And again, after the stem cells has remarkable improvement. Now he is in college in doing that. So subsequently, these are the 2 reference cases that we reported in our report in 2017. We have about 12 patients who received autologous mesenchymal stem cells infusion therapy. And still we are in actively following 8 of these 12. And these patients report that improvement in most of them. Only 2 patients that out of these 12 patients, they reported no change in their symptoms after that. So I have to say that, it's not like we are saying that this autologous or stem cells has 100% improvement rate of those one. So we have to accept that some of them, and particularly in our patient cohort, and it is very hard to say that this is a study, but in our patient cohort, 2 out of 12, they didn't respond very well for this. It's something that it can be encouraging to study this in more of what you call it, case control studies, and seeing this in relationship with the autoimmune part, which we were doing for a lot of these patients. And we saw that the autoimmunity has been really modulated with those patients who received the mesenchymal stem cells. Excuse me. So in summary, so patients with orthostatic intolerance symptoms, they can have a high probability of autoimmune components. In our cohort is 84%. That's really high. And several studies they have shown that the relationship between the immune and autonomic nervous system. So it's not like, this is something that new. Since 1990s, people they found out the relationship between immune and autonomic nervous system. Mesenchymal stem cells have one of their properties decrease inflammation and serum markers in general of inflammation. And this is very important. That's what we are using this stem cells for, is the inflammatory process that we see. So as we saw that antibodies titers are increased, especially the cytokines in those patients. So this is where mesenchymal stem cells can help with that. So also the systemic, the central nervous system and especially the autonomic nervous system in the has a big autoimmune inflammatory marker that has been called the reflex of the inflammatory autonomic reflex of those. And it can also, acetylcholine receptors are in multiple organs and reticular endothelial system. And that can explain that why these patients that who has POTS or a neurocardiogenic syncope, why they have multiple systems that it is involved in that. The ganglionic nicotinic acetylcholine receptors antibodies is an entity. It's mainly in mid-age women mostly, and for some lower extent in men. And those they responded very well also for modulation of their immune system. And mainly they are using the intravenous immunoglobulin for those, but also they have been using combined steroid and also cytotoxic medication to improve that. And this is probably what I have today. So I will be happy to entertain some questions from you guys.
Great. Thank you so much for your presentation. Oop, it's a little dark. I can't decide if it's too bright or too dark in my space, but that was very, I think a lot of details, a lot of heavy science in there. So I think we have a lot of questions. I just wanted to mention, I put something in the chat that's a Dysautonomia International quick links. It's a PDF folder that flyer that has a whole bunch of links in it to different helpful resources. It's a good way to sort of get at some of the best stuff that we're offering for patients and caregivers to connect with each other and other educational resources. All right, so let's jump into the questions. Please, as I mentioned earlier, try not to make your questions too specific because doctors can't give individualized medical advice over a Zoom webinar. If they can be broad questions, that's more helpful. And also, please don't be mad at me if we don't get to your question because we have lots of questions. Okay, so is it possible for stem cell therapy to make symptoms worse?
That's a good question. I mean, theoretically, it shouldn't be because, as I said, mesenchymal stem cells is anti-inflammatory. Now, the process of giving it because intravenous fluids has been given, and usually they will give it into doses over 2 days. It has to be given with steroid, and that's the way because that can decrease the inflammation that can come in with the stem cells. Although it is autologous, means that the same person taken, but there is response by inflammation for stem cells when you give it immediately. So this is why we give it with steroid in the same time. So the possibility of inflammation or activation of inflammation with the stem cell infusion acutely is possible. Yes.
Yeah. So there were a couple questions from people who collected stem cells from cord blood when they had given birth to a child or a sibling. And do you know if there's any examples or has anyone taken stem cells from cord blood to do stem cell therapy on a sibling that, the cord blood came from the healthy sibling and the other sibling has a devastating autoimmune issue?
I didn't have any experience with that. I know that there are some studies now. There is a big study about EDS and Ehlers-Danlos syndrome and stem cells conducted in California, and they take donors' stem cells and to give it to people who has that, and it might be promising results. We don't have the actual results, so I can't talk about it for the time being. But in the same time, remember, you need the mesenchymal stem cells. Why it is that? Because the anti-inflammatory process of that. Remember, cord stem cells, they differentiate to everything. They called white cells, RBCs, bone cells, myocytes, muscle cells. So you want specifically an anti-inflammatory cells, which is the stem cells that it can modulate the inflammatory process of the cytokines. So that's in theory. I don't have a practical answer. I didn't know any study that they look at umbilical cord stem cells transfusion for those patients. But that's the theory that the
Yeah.
stem
Oh,
cells
I
will
think you
be
cut
there.
out. I'm not sure if it's just for me because of my internet or if others were having trouble you hearing there for a second. Can you
Or
hear me?
okay, can you hear
Oh,
me
it
now?
might have been my internet.
Okay.
Um, so I do know from other diseases where like often things like cancer where cord blood is used to try to help a sibling. It doesn't just because you're a sibling doesn't mean that you're a match. There's very specific biomarkers that have to line up, and that doesn't always happen. I believe that a sibling with the same two parents, it has like basically a 50% chance of being a partial match and only a 25% chance of being a full match. So there's a lot of complexities there. And I think there's barely anything in stem cell therapy and dysautonomia. This is sort of it that you're seeing. So in other diseases where a cancer and sort of other fatal diseases where things are, they've looked at this a little bit more. There's probably some research that can give you some hints on that, but it's not something that we're seeing happen in the dysautonomia space yet. We're hopeful that, as the immune research and autonomic disorders progresses, we'll have more options available. So I noticed, and a couple other folks have asked questions about this. Your patient number one was on cromolyn. So that suggests she was having like a mast cell problem, mast cell activation syndrome, something like that, allergic reactions, right? Was she able to get off the cromolyn after the stem cell therapy? And did she see an improvement in her mast cell symptoms as well?
Absolutely. Now she has only three medications. Out of all the medication you saw in her list, she's in propranolol, midodrine, and pyridostigmine. These are the only three medications that she's taken now. So we weaned her off all the other medication, all the Florinef and all the the cromolyn sodium, and also of course octreotide and all these things. We took it off her medication list because she improved a lot only
Yeah.
on these three medications.
I think it's such a challenge to know what's causing what, right? Because I think a lot of people just assume, oh, the mast cells are causing the dysautonomia. It might go the other way around. The autonomic nerves regulate the immune system cells, so it could be a bidirectional relationship, and more likely because there's so much overlapping complexity between the neural signaling and the immune signaling, it's probably not a two-way street. It's probably like a 10-way network, which is probably why it's been so hard for researchers to figure out what's
And
causing
honestly,
what.
also, Lauren, as we know that, the association doesn't mean causation, right? So,
Right.
and this is very important concept in medicine that, we see association of dysautonomia with a lot of things. One of them is autoimmune, of course, which is very strong. Ehlers-Danlos is another association that has been, of course, there is some psychological diseases and psychiatric disease. So a lot of people they will say, "Oh, you are depressed, you are you have anxiety," and in matter of fact, that probably the anxiety and depression is secondary rather than a primary. So the association does not mean the causation, and that's what
Yeah.
we see also in the activation of mast cells and EDS. That it is associated. We know that, and there is a very strong evidence of association, but I don't think we can say that this is caused by this.
Right. I think the answer is we need more research to figure out what's causing what, and it might be different in different people because these are very complicated regulatory systems. Okay, so here is another question. How many stem cell therapy infusions do people usually have to do, and for how long before they see improvement?
That's very interesting question because this patient particularly, which is reference case number one, she received three doses 6 months apart. So once they will take your adipose tissue, they will get the stem cells, multiplication outside your body. So you don't have to do the adipose tissue or the extraction of the fat from the abdomen or the thighs each time that you do, the stem cells. So one time, and then they will bank it for you and multiply it. And this is true not only in this lab that we dealt with, it's most of the labs that they deal with stem cells. Now, usually they will respond for the first 2 doses of the stem cells. So that means the first 1 year of the stem cell therapy. Sometimes I have 3 patients, I think. They received about 4 cycles of stem cells 6 months apart to see the improvement of their autoimmune. Luckily, that this patient, the reference one, she was so much having autoimmune that has responded very well after the second dose of stem cells.
There's some folks asking if there's a journal article on this. So I'm sharing a PDF of your paper that you wrote a few years ago on this. Made me make sure I have the right one. Did you write a second one at autologous adipose stem cell therapy for
This
autonomic
is the one. No,
dysfunction?
no, this is the one that we wrote. That was in 2016. Yeah.
Yeah. Did you have another one since then?
Unfortunately, we are planning to do one. Our thought process is to do actually a control study. That means that people who will receive the stem cells, people they will not receive the stem cells. They will have IV infusion of normal saline or something,
Right.
and we look at that in more of control study. And that's a little bit difficult because the IRB, and when it comes to sham study, they have a lot of questions, especially if it comes younger patients, it needs the consent form and things like that is very complicated. So still we are
Yeah.
waiting to do this, and the funding is also a major thing that we are waiting, because stem cells, those ones, it can be expensive, because they are done by private labs and things like that. So it can be expensive.
Yeah. So I did put that link in the chat if anyone wants to download it or take a look. Someone said, can I show this paper to my doctor and get them to do this? I think it is, I'll just be honest, I think it's very, very unlikely you're going to find any doctor on the planet that will do this for you, other than maybe Dr. Newman. And really, you weren't actually infusing the stem cells, right? Your patients were kind of just going off on their own and doing this, and you're sort of
That's right.
reporting what they
I can't
did.
I can't actually say it to my patient because it's still not an indication by FDA. Yes,
Right.
it has been approved for cancer therapy and transplant, because it can decrease the inflammation of graft versus host inflammation. It has been shown that, and now there is MD Anderson down the street from us. They are using it for that purpose. But
Yeah.
there is no indication for the IND to be used for the dysautonomia.
Right. And that's, there's a lot of regulatory things that have to happen
Yeah,
before doctors can even do research on a treatment like this that is way beyond just the doctor wanting to do it. It's FDA and their own university, like lawyers getting involved, and so
yeah,
very kind of
yeah,
it's very, very actually challenging to do research, even when you have a super well-intentioned doctor that wants to do it, and even when you have funding available, especially in children. I found that from Dysautonomia International's work, it's very, very hard to get research happening in kids, which is hard when you have a condition that very often starts in childhood. Um, is there a place where people can read the list of antibodies and the data that you showed, the high percentage of antibody positive? Is that a journal article I could share a link to?
yeah. We did an abstract. Unfortunately, only we didn't do a journal article. I'll put the slide of the antibodies here
Yeah.
for anybody that he can.
Was that a CAR abstract that I can find?
Yeah, this is in actually Autonomic AAS abstract.
Yeah, it would be in CAR, right?
Yeah, it will be in clinical research. Yeah,
Okay.
yeah,
I will try to dig it out, and when we email out the link for um the video, we'll try to include a link in the email to the
yeah,
abstract if I can find one. Sometimes they're kind of buried, but
yeah.
um Okay, yeah, there's also, we're trying as an organization to get more doctors to do this stuff clinically where they're screening their patients for a lot of potential things where, not every patient is going to have the gastric parietal cell antibody, but until we start looking and then figuring out which patients had which antibody, we're not going to know how to pinpoint that testing, right?
Yeah,
Like the ideal
absolutely.
scenario would be patients who have these two symptoms should get tested for this antibody, and we're not quite there yet because our patients have so many different things going on. So when you're talking
So,
to other patients online and they have POTS or they have dysautonomia just like you, they could have a very different biological mechanism causing it or contributing to their overall health stuff. It's very important that we remember that as a patient community that
and that's
we're
why we study a panel rather than only one antibody. As you said, there is nothing that we link to. I know that gastric parietal cell makes sense for some people, but in the same time, we don't only study the gastric parietal cell antibody. We have to
yeah.
combine it with the other, as you can see here in the panel. And this is where it will become more informative to you than doing only one antibody or one because some patients they will come to me, oh, they studied my ANA and I was negative. Okay, ANA is important, but in the same time, it's not the only antibody that we look for, and that's why cytokines and the other antibodies are important to be included in this.
So some folks are asking, what is the name of the clinic in Mexico where they do this?
It's a company actually. It's called Celtec. It is stationed in Houston, and they have a physician that collaborate with them, and they do the actually nowadays they are doing it in the United States. After COVID, I think they got permission to do these infusions here in the United States. So you don't have to
Yeah.
fly to Mexico anymore. You can do
So
this here in Houston.
yeah, I want to be careful and making sure when people are listening to this and talking to their doctors about it, like Dysautonomia International is not promoting this as a treatment approach for everyone. We're sort of sharing this as research update and something we really want to see a lot more research on. But we also feel like patients and parents have a right to be informed about what's going on and, work with your own doctors to make the best decision for yourselves and your loved ones. um, so there are definitely some doctors in the dysautonomia space that will probably send me a cranky email like, why did you tell patients about this? Because they don't want to have to answer questions about it and why they're not looking into this. you know. But I think it's important as a community that we can talk about controversial things and just recognize like the research isn't fully there on this yet. This is just a small case series, but we know how incredibly sick some of our patients are and that they've tried everything standard and it's not helping. In the same line of thinking, like you mentioned that this patient had gotten plasmapheresis and IVIG, and like that's out of reach for most patients here in the US and abroad. We have funded some of the first IVIG research in autoimmune POTS, and actually we're currently funding the first plasmapheresis trial in autoimmune POTS. Um, and so, there's a lot of stuff in the works, but it does take a very long time for that research to get done. And for then to that sort of, even if the results go well, for that to then translate into, can I go to my local doctor and get this?
So,
Um,
Lauren, you mentioned very important point that the plasmapheresis and IVIG, both of them are related to the stem cells in an anti-inflammatory process. Because, as you know, plasmapheresis, you remove the cytokines and the inflammatory markers from the body or the serum, as well IVIG are suppressing these immune respond this one. So it makes sense for people that to direct their, especially we are talking about severe forms of autoimmune dysautonomia, that directing that to the immune system rather than only giving midodrine and florinef. I mean, these can help definitely, but it can be that we need to dig deeper into the autoimmune. As you said, Lauren, we are not advocating a certain therapy like plasmapheresis for everybody or IVIG for everybody or stem cells for everybody. We need to study this in more details, but it is coming strong that autoimmune is really playing a major role in dysautonomia.
yeah. And I would also say, a lot of times when we're talking as patients online, we kind of trade notes on who's testing for what and who's got, who thinks this is causing that. It's a lot of people trying to figure out what's going on because they're so sick and they just want answers. And for a long time, we've heard people say, oh, well, I have EDS, so I don't have autoimmune dysautonomia, or I don't have autoimmune POTS. And I think we need to emphasize, like, at least from the data that I have worked on as a researcher, the EDS POTS patients are actually more likely to have the autoimmune and inflammatory stuff. So there must be some kind of relationship there between hypermobile Ehlers-Danlos and some risk of autoimmunity. And so there's very recent research that came out of Medical University of South Carolina in the past year showing different basically, they found some genetic markers in not everyone with hypermobile EDS, but a subset of patients. And it's a gene that alters immune function and connective tissue. So these things kind of go together, right? Your immune cells kind of come out of have like a very tight relationship with your connective tissue cells. So don't assume just because you have EDS that you can't have this immune system stuff, and vice versa. Just because if you have Sjogren's associated POTS, you might also have EDS, right? It might have an
And
overlap.
we see that a lot. Yeah,
Yeah,
absolutely.
a lot of us, I think, as patients, we get diagnosed with what our doctors are interested in. If I went to I have all this stuff. If I went to a pain management doctor, they'd say, "Oh, you have fibromyalgia and migraines." And if I went to a neurologist, they'd say, "Oh, you have small fiber neuropathy." And if I went to a cardiologist, they'd say, "Oh, you have POTS and some IST and some syncope." Right? And then the GI doctors say, "Oh, you have IBS or gastroparesis." And it's like it's very frustrating as patients, you have all this stuff going on and you need people to put it all together. And I also think that happens with the comorbidities, right? If you see a Lyme doctor, they're going to diagnose you with a tick-borne infection. If you see a chronic fatigue syndrome expert, they're going to diagnose you with chronic fatigue syndrome. So I'm not making fun when I say this. Like, it's happened to a lot of us as patients. You go to a different doctor, they give you a different label. And then especially if you're a young person, that can feel very emotionally overwhelming to have like 15 diagnoses when you probably just have one or two medical problems causing all of this stuff that we just haven't figured out yet as a researcher
And
community,
that's why
right?
I emphasize the point, Lauren, during the talk that, the autonomic nervous system, it goes deep into the tissue. It's reticular into it's spleen, pancreas, liver, intestine, stomach, heart, blood vessels, lungs. So that can explain why these patients, they don't have only tachycardia or hypotension. They have a lot of comorbid things that it is related to the deep autonomic nervous system going into that. And
Yeah.
remember also, there is an idea is called cross-reactivity. Means that if you are having positive antibodies for some disease, you can cross-reactive with other diseases. And that's where you can get the confusion part. When you do a serum, for example, for Lyme, and you have high cytokines, there will be some cross-reactivity sometimes between this. So we have to be aware of this cross-reaction between the
And I also think
titers.
people who are prone to chronic immune system dysfunction, you probably have some underlying genetic risk factors for immune dysregulation.
Yeah.
I've actually found that in a research study that I led, wearing my neurology professor hat, that POTS patients have HLA markers, which the human leukocytic antigens are the genes that sort of like regulate your immune function, your big picture immune function. And they had HLA genes that are known to be associated with an increased risk of autoimmune disease. And so things can be a genetic disorder and an immune system disorder, kind of can go together. Um, so anyways, my point in saying this is that once you have that sort of risk for one immune system dysregulation, you might have risks for others as well. I have Sjogren's, and I've also developed antibodies to a bunch of other stuff that isn't Sjogren's, but not quite enough to get all the other things diagnosed, right? I think a lot of our patients live in a gray area. Like, your patient had 1,000,001 different immune markers, but they didn't have like a clear autoimmune diagnosis, right?
Absolutely not. Yeah.
Yeah. So that's really frustrating. You can tell the patient is sick because they have immune dysfunction. So are there who are the doctors who are sort of looking at the immune biomarkers in dysautonomia patients in your opinion, who's taking the careful look at immune markers in their patients clinically?
I would say rheumatologist more than immunologist. I see more rheumatologists are interested in this. Recently, we had 2 or 3 rheumatologists who came to our clinic to see more of these immune markers and how is the relationship between them and the symptoms that the patient they will get. I think rheumatologists are the ones that we need to collaborate very well with those.
Yeah, there is actually a Britt Adler at Johns Hopkins she was originally part of the Sjogren Center and the Lyme Center at Johns Hopkins, and she's now part of their POTS Center there, and starting to take a look at autonomic nervous system deficits in a broad swath of all their different autoimmune patients. Hopkins has a bunch of big autoimmune clinics for different diseases. So they're looking at that, and they're also she's been giving lectures at the big annual American College of Rheumatology conference on POTS and orthostatic intolerance every year, which is kind of cool to see a new discipline sort of getting lectures on this at their big medical conferences. My personal experience is that rheumatology has not been very helpful to most dysautonomia patients, but it's a hit or miss, right? I think it's very individualized at this point. I
Absolutely,
know, I know
absolutely.
that Dr. Goodman out in Arizona is very careful in looking for immune markers. Dr. Shamali is careful. Dr. Blichstein up in Buffalo. I think that each of the doctors has their own kind of what they look for. Dr. Novak at Harvard has a very long immune panel that he looks for. And it's because when people have markers on his panel, he tends to be able to get them approved for IVIG if they also have neuropathy of any form. So he's looking for immune markers because he's got this treatment that he can maybe possibly get you if you have these markers. And it's a similar list to this, but it has other neurological markers on it. I would love to get all of you together and say, hey, what is the big list? What?
Good luck.
We're like 45 tubes of blood, what do we
Yeah.
need? But really getting the research done so we can narrow this down and tailor it to the individual patient and know like the patients with these symptoms need these tests. And I think that is a lot of that is what prevents primary care doctors from wanting to really dig in and help these patients because it's like an overwhelming amount of stuff they have to know, right? Are you there? Can you hear me?
Yeah.
Oh, okay.
I'm,
So
yeah, I'm saying that good luck with getting all of these people together, you know.
yeah, well, we get a lot of you come to the conference, so maybe
Yeah,
we'll do
yeah.
that. But anyways, thanks so much to everybody who tuned in. I know this is kind of a pretty science heavy talk, and I wish I could tell you that, yeah, there's this great doctor down the street, you should go get this treatment, but we don't really have that yet. We want people to be aware of it, and we want people to understand why it's so important to push for more research to happen, to push for your clinicians wherever you're being seen, to push for them to learn more about dysautonomia and what's going on in the field. Because I guess, the moral of the story is it's a lot more than salt and fluids that we need to be doing for these patients.
Absolutely. Yeah.
And new research is going to help get us there so that we can improve the clinical care. So thank you so much for your time, Dr. Newman. I'll let you
Thank
go.
you.
I'm sure you have to go home and have some dinner at some point. Can't keep you all day. But we will send this video out to everyone, and in about maybe 2 weeks, it usually takes to do the editing. So thanks so much. Have a good night.
Thank you.